Sorry, the microphone was muted. So today we're doing the vascular tree. It's for both for year 1 and year 2. And essentially what we'll cover is the blood vessels and the supply in the abdomen and the limbs. So the contents page, we're going to start with the vascular tree itself. What does it mean? Why is it organized in such a way? Then we're going to move on to the circulatory system, so the structure and function and the differences in the blood vessels. We'll also cover the divisions of the aorta, so the arch of the aorta, thoracic aorta, abdominal aorta, and where they arise from and what they supply and their importance clinically. We'll also talk briefly about the site of pulses, and we'll have some sample questions which cover histology and any sorts of other questions that you might encounter for the vascular system. And once again, question and answers. And as always, it's going to be all made available within 24 hours. I do apologize, the microphone was muted in the early section, but this will be the last video we do for the week before you have your exams. Next 2 weeks we'll be covering a live Zoom sessions where it will be multiple tutors going through multiple topics. So stay tuned for that. So first things first, what is meant by vascular tree? So a vascular tree, it's a way to describe the blood vessels. So the blood vessels, they're highly ramified, which means they have a lot of branches. And we have the common trunk. It's formed by the aorta, and if you can imagine the aorta as the trunk of the tree, and then we have branches which are the peripheries. So this could be branches from the brachiocephalic tract, from the left ventricle. It's all different branches that supply different parts. Now there can also be some depictions here. So this is the liver. So as we can see, it looks like a tree. So if you would have the aorta in the middle here, so if we have the aorta in the middle and this branches out, so that looks like a tree branch, and it's the branch of the tree. So it's a way to sort of talk about the ramification and the high denseness, as you can see here, of the vascular system. We also, so that's a vascular tree. So here we have both the venous and the arterial supply. So this would be the venous tree and the arterial tree, and together they make the vascular tree. Now we can have variations to the divisions. So you can have short trunks, you can have subdivisions, you can have vessels that give off branches, or they continue as the main trunk, or the vessels can divide, such as the splitting of the common iliac. And this is a drawing here where we can see the different blood vessels and the arterial tree. So we start from the tree trunk here, that's the aorta. We bifurcate here with the common iliacs. On the top here we have the brachiocephalic, and then we also have the left common carotid, which makes the circle of Willis, and then blood supply to the neck and head. So it's a very complex structure. And we can sort of see that it's like a tree. So the more further out we go, the more branches it has, the more ramified it gets. And essentially it allows for the perfusion of the peripheral part. So the peripheries will be like the tree branches, the center is the tree trunk. Now let's have a look at a blood vessel. So the blood vessel here, we have an artery, we have a vein. Those are two main categories of blood vessels. And they have 3 layers. So we have the tunica intima, which is the inner layer surrounding the lumen, the media, and the adventitia. Now the tunica media is the innermost layer of the blood vessel. It's single-celled usually and squamous epithelium, and the whole function is to reduce friction. So as you can imagine, red blood cells are quite thick, and they are the solid part of the blood, and they can cause friction. So 45% of the blood is cells, solid cells, so you want something to reduce the friction and line the vessel. Then we move on to the tunica media. So this varies in degrees of thickness. It's thicker in arteries and thinner in veins, and these are made up of smooth muscle. Now the pressure of the blood that flows through it depends on the level of the contraction of the tunica media. And certain vessels have more of the muscles, and certain cells have less. And that's because of the different functions of different arteries, which we'll get to. It's a smooth muscle, so the response to the sympathetic nervous system and hormones. If we vasoconstrict, so that means reduction in the radius, right? That's vasoconstriction. We increase pressure, and vice versa for vasodilation. We dilate and therefore we decrease pressure. We also have some elastic tissue fibers which can provide passive recoil, and in the case of that causes the pulse. And we also have some folds here within the veins which cause these valves to form for unidirectional flow. Now the tunica externa is the outermost layer. It's fibrous connective tissue. It's very thick. It's a protective layer, and it ensures that the blood vessel has strength, which becomes important when you have aneurysms. So you want to, there's a lot of blood going very quickly, so you need to have a thick sort of supporting layer to ensure that the blood stays there. We also have something called the vasa vasorum, which are small blood vessels. So in very big arteries, the diameter is so big that you can't get blood perfusion on the tunica adventitia or tunica externa. Those two are interchangeable. So tunica adventitia or externa means the same thing. So you need blood vessels to go into the tunica adventitia to give the cells their blood supply. So you can have certain small blood vessels within large arteries. So we move on, and these are the different vessel types. So we have the large veins, elastic arteries, medium veins, muscular arteries, venules, arterioles, and all the way down to the capillaries. Now let's talk about arteries and arterioles. So their function is to provide blood away from the heart. So it's oxygenated blood from the heart to the peripheries. The only exception for an artery which does not carry oxygenated blood is the pulmonary artery. And the pulmonary vein carries oxygenated blood back to the heart. That's the only exception. Then we move on to the capillaries. So they are the sites of exchange of water, oxygen, nutrients. This is the as we go further down the level here, these become more numerous, right? So it becomes much more denser. So we have this dense network of capillaries and capillary beds, and they perfuse the tissues with blood. And you have this leakage through these capillaries, which is caused by hydrostatic pressures, and they produce interstitial fluid, and that drains to the lymphatic system. But what's important here is that they perfuse the cells and the tissues at the smallest level. Then we have our veins and venules, and they return oxygenated blood. The only exception is pulmonary veins. Now when we look at arteries, we have an elastic artery. And these are the big arteries. So these are very thick, major arteries. It's the direct branches from the aorta. They will be called elastic arteries. And the reason they're called elastic arteries is because they contain elastic tissue in the tunica media. So in the tunica media, they have elastic tissue. And this extra elasticity is required because you're so close to the heart. So when you have a strong contraction, it's a lot of force. It's a pump, right? A lot of force going through the blood vessels. You need this elastic sort of recoil to allow the blood vessel to stretch. And this is what causes the pulse. So you need the blood vessel to stretch and then come back to its place. If you didn't have the elastic tissue, then you would have permanent enlargement of the blood vessels. Now, as you get older, sometimes you can have fewer elastic tissues. Or let's say you have a congenital deficiency where you do not produce this elastic parts. Well, then you can get a dilatation of your elastic arteries, which can cause all sorts of problems. Moving down, we have something called the muscular artery. And it's a very common type of artery. It's a distributing artery. So these are the arteries that you usually see branching off, right? So let's say you have a branch of the aorta, like an SMA, so the superior mesenteric artery, or the brachial artery will be a muscular artery. And the tunica media is much thicker, but the tunica externa is quite thin when you compare it to the elastic artery. And this is because the blood's been already going through this thick elastic arteries and it's getting distributed. So it doesn't need that extra protection. So tunica externa here is very thin. We move on to the arteriole here. So the arteriole is quite simple. It doesn't have a tunica externa. It's comprised of the tunica media, and it's usually 1 or 2 cells thick. So these are your arterioles, and these are the ones which constrict. So you have vasoconstriction and vasodilation, which changes the diameter. And as I said before, as we go down, lower into the smaller arterioles, they become more plentiful. So we increase the surface area, so to speak. So if the arterioles down there constrict, and a lot of them constrict at the same time, well, suddenly you have constriction, which changes the diameter and increases pressure. Do it the other way around, you have vasodilation, they dilate, and suddenly you have decreased blood pressure. So the arterioles are very important. They mediate the blood pressure here and the perfusion. Moving on to veins. So the large vein is your in the veins in general, you have a thin media and a thick externa. And thick externa is so that it allows it to be protected. You also have the folds within the tunica intima, which create the valves to allow unidirectional flow. And as you can see, the percentages, or like the relative thickness of the tunica externa to the media, is maintained. Then we go to the venules, where the tunica media is very thin, almost non-existent. And this is because if you have the muscle there, it's much more difficult to move the blood back to the heart. So venules, for example, or even smaller veins that are found in your foot and in your legs and in your lower limb, they are pumped by the action of the muscles. So it's the contraction of the soleus muscle in the leg which pumps the blood up. This is why people who are immobilized, they get pooling of blood and can get clots. So the fact that they don't have this muscular layer is so that you can actually squeeze them when your muscles contract, pushing the blood in one direction. And the valves sort of stay there to prevent backflow. So that's why the veins have quite thin media. Now we have capillaries. We have 3 different types of capillaries. Continuous and fenestrated ones are the most common. We also have sinusoids. So continuous capillaries, they permit very small solutes. They usually come from the arterial side. And they're found in every tissue except for epithelia and cartilage. You don't find them there. So cartilage and epithelia. Fenestrated tissues, so they have these pores. That's what it means. Fenestration means a window. It means a pore. And they allow larger components through. So these are your proteins. And the reason they have these pores is because they're incomplete linings. So they're not fully complete. And the endothelial cells, they have these gaps. Sinusoids, they're much more bigger and they allow free exchange of water and plasma proteins. And you can find these in the spleen. So we've covered the different blood vessels. Now we're going to move on to the course of the aorta. So the aorta starts right at the aortic knuckle from the heart, and then it goes up, forms the arch, and then you have the thoracic part of the aorta. Then you have the abdominal, and then it splits into the iliacs. So as I said, we have the ascending part of the aorta with the aortic arch, and it arises from the aortic orifices, and it forms from the left ventricle, ascends to become the aortic arch. It's roughly 5 centimeters in length, and what you have here is you also have the origin points for the aortic sinuses, where they give rise to the left and right coronary arteries, which supply the heart. We then have the aortic arch, so it's a continuation of the ascending aorta, and we have several different branches coming off from here: brachiocephalic, and the left common carotid and left subclavian. When we move on, we have the next part, which is the thoracic. So that goes from the descending part of the aorta all the way to the diaphragm. From the diaphragm to the branching in the common iliacs, we have the abdominal aorta. And this is just me labeling them here. So when we look at the aortic arch itself, so this is what we're looking at, right? So we have, as I said before, the first part right here. I'm going to do this in a different color. So this part right here, That will be the first part, that's the ascending aorta. And as we see, we have the first branches, so these go to the heart, right, to the heart. So they go to the heart. Then we have the first parts, which are the arch of the aorta. And here the first branch is the brachiocephalic. And the brachiocephalic goes into right subclavian and right common carotid, which goes to your head and neck and your upper limb. The left common carotid goes to the left side of the head and the neck, and the left subclavian goes to the left upper limb. Now the course of the arch of the aorta is from the second sternocostal joint. So you have to look at the sternocostal joint here, and it goes all the way to the T4 level. So that's the sort of distance of the arch of the aorta. And the branches, as we said before, brachiocephalic, left common carotid, left subclavian, and they supply the upper limb, right? Upper limb, upper face, everything basically from the shoulders up is supplied by the arch of the aorta. So the next one is the thoracic aorta. And this starts, and this is in the thorax, so it starts from T4 and goes all the way to T12. And where it starts is that it starts at the left of the vertebral column. So if we imagine looking from a sort of a coronal view from the front, we will see that the vertebral column goes to the left, but then it approaches the midline and it is in line with the vertebral column. And it pierces the diaphragm through something called the aortic hiatus at T12. And a good way to remember that is that aortic hiatus has 12 letters, aortic is 6, hiatus is 6, and therefore that's T12. The esophagus has 10 letters if you spell it with an O, and that pierces the diaphragm at T10. So that's a clever little mnemonic there to help you remember these sort of arbitrary things. So there are a lot of branches in the thoracic artery. So we have bronchial arteries. So they are paired arteries, and they supply the peribronchial tissue and the pleura. We have mediastinal arteries, which supplies the lymph glands and the areolar tissue. We also have esophageal arteries, which supplies the thoracic esophagus. We have the pericardial arteries, which supply the pericardium, so the dorsal portion, so in the back. We have superior phrenic arteries, so anytime you see phrenic, that's to do with the diaphragm, so they supply the superior part of the diaphragm. And then we have intercostals and subcostals. And we get 9 pairs of these. As you can see, they sort of branch out and they go into the intercostal muscles. So if you can imagine the ribs coming from the front here, if you have like a rib coming through here, you can sort of imagine the arteries flowing through there as well. Now we have 9 pairs of intercostal arteries because they supply the spaces. And the first 2 are supplied by the subclavian. So that's why we have 9 pairs of intercostal ones, despite having more intercostal spaces. So the thoracic aorta, pretty basic. It just supplies the surrounding regions of the thorax, right? It's quite self-explanatory. Moving on, we have the abdominal aorta, and this is the sort of the meat of everything here. It's a very complex structure here. And this is sort of where you have to remember everything and the relative blood supply layers that it sort of supplies. So the abdominal aorta, it spans from T12 to L4. It's roughly 13 centimeters long, and at L4 we have this bifurcation for the left and right common iliac artery. So right here bifurcates. So we have several branches. We have at T12, the most important one is the celiac trunk. So we'll cover the celiac trunk a little bit later, but celiac trunk is T12. And what that does, celiac trunk T12, it helps supply the liver, stomach, abdominal tissues, such as the abdominal esophagus, spleen, duodenum, and superior pancreas. So celiac trunk, very important to know the anatomy here. We also have inferior phrenic arteries, so these are important for the diaphragm, so it's the posterior part of the diaphragm. And we also have the middle suprarenal arteries, so these supply the adrenal glands on top of the kidneys. At L1 we also have a lot of things happening. So at the lower level we have the superior mesenteric artery, which is superiorly, and then we have the inferior mesenteric, and this supplies the mesentery. So it's the distal duodenum, jejunal ileum, ascending colon, and up to the first two-thirds of the transverse colon. And the reason it goes to the anterior two-thirds of the transverse colon is because of the embryological ending of the midgut. So from the two-thirds of the transverse colon, the midgut ends and the hindgut begins. Then we have the renal arteries. They are at L1 to L2. They are right between, so the right renal artery is between the IVC, so the inferior vena cava, and it goes behind. Therefore, it's a little bit longer because it has to go behind. This was an exam question for us. Why is the renal artery longer? Because it has to go behind the IVC. And from there you have the inferior suprarenal. Now, the adrenal glands have a variable blood supply, and same thing with the kidneys, and it varies from person to person. So when a kidney surgeon or when a transplant surgeon is looking at this, he needs to get a good picture and a good view through MRI and all these other imaging techniques of the blood vessels, because the anatomy varies greatly from person to person. At L2 we also have the gonadal arteries. So in the males, that's the testicular artery, and in females, that's the ovarian artery. Very important here. And they go down and descend. At L3, we have the inferior mesenteric artery. So this goes from the lateral 1/3 of the transverse colon to the splenic flexure, and it goes down through the hindgut. So this would be your descending colon, your sigmoid colon, and parts of your rectum. So inferior mesenteric, very important. And it's very important when you do surgeries, when you try to remove pieces of bowel, you need to clamp this artery and this one here as well. We then go on to the median sacral artery, which sort of sticks at the bottom, and this supplies the coccyx, the lumbar vertebrae, and the sacrum. We also have lumbar arteries, which start from L1 all the way to L4, and they supply the abdominal wall and the spinal cord. And lastly, we have the bifurcation at L4, the right iliac and left iliac, and they go into the right external and right internal, left internal and left external. And at the inguinal ligament, at the hips, it becomes the right femoral artery. So why is all this important? Why do you need to know about the aorta? So if you want to be a surgeon, it's very important to know about the different blood supplies, what areas to avoid, where if you have a tumor, it can sort of get into the IVC and even to the aorta in the worst case scenario. But from a vascular point of view, you're interested in an aneurysm. So aneurysms can happen anywhere along the aorta, but they most commonly happen infrarenally, so below the kidney, so below L1, L2. If you have them suprarenally, it's called a thoracic aneurysm. If it's beneath that, it's an abdominal aortic aneurysm. And what an aneurysm is if the diameter right here, this diameter exceeds 50% of its normal diameter. So if it expands like this, that's an aneurysm. And that's a problem. And it's a problem because it can cause pulsations, pain in the back and pain in the abdomen. But it's even worse if it happens if it happens right here in the thoracic area, it can cause a hoarse voice, so the left recurrent laryngeal nerve can be impacted. But oftentimes it appears, it's an incidental finding. And the older you get, the more dilated it becomes. And if the critical value, so if this gets to 5 centimeters, roughly 5 centimeters, right? If it gets to that size, well then that's a problem. And once it gets 5.5, that's when you start thinking about operations. Now what happens is that if it becomes too dilated, it can just rupture. And this is a medical emergency and it's often fatal. So you want to get this sorted really quickly. And the risk factor is usually men, and the older they get, so men above the age of 70. And the way you look into this is through an ultrasound. And you'll see the weakened vessel wall, and it usually gets replaced surgically with synthetic tubing to avoid the aneurysm. But yeah, so this is the importance of the the aorta and knowing what gets affected where. So we'll talk briefly about the celiac trunk. So the celiac trunk here is quite complex. It supplies a lot of the top part of the abdomen, a lot of the important organs there. But we can simplify it quite easily. There's sort of three main branches to sort of think about. So the first branch is this is the splenic one, so that's number one. Splenic one. Number two is this left gastric, so that's number two. And number three is the hepatic, which goes to the liver. Now, the way to look about this is that one artery goes to the right and two go to the left. So the one that always goes to the right is the liver, the one for the liver, so the common hepatic, and then the left gastric and left splenic go to the left. So the left gastric, it sort of rises up here across the diaphragm. So if you can imagine the diaphragm on top of here, diaphragm is right here, and it gives rise to esophageal branches when it goes towards the abdomen here, so towards the diaphragm. So this is the esophageal branch. Now, if it also courses anteriorly, so it sort of goes along the lesser curvature of the stomach. So that's the lesser curvature, that's the greater curvature. So it goes along the lesser curvature of the stomach in an anastomosis with the right gastric artery. So there's that branch there, and this supplies the whole lesser curvature. And that's the left gastric, basically. The splenic artery is a little bit more complex. So it's often inferior to the left gastric artery, and it goes sort of behind the stomach. And it travels towards the spleen, and it goes along the superior margin of the pancreas. So if you can imagine the pancreas here, I know this drawing is not very complete, but the pancreas would be roughly around like so. Right? So pancreas is right sort of there, like this, and it goes along the course of the pancreas. Now it has, it's found within something called the splenorenal ligament. So the splenorenal ligament is a ligament through which this blood vessel travels, and it terminates into 5 different branches which supply the spleen. So at the spleen you have 5 different branches. Now the shape of the artery is very important. It's tortuous. So if you can imagine as a surgeon, you're digging around and which artery is which. So you need to have some sort of landmark. So the splenic artery is the key landmark here because it's tortuous. What the hell does that mean? Tortuous means that it sort of winds up and down, and it sort of snakes behind the abdomen. It's quite long and quite obvious, and it has these 5 branches. And its tortuous appearance makes it very clear to sort of identify. Now, as the splenic artery reaches or approaches the spleen, it gives off other branches. And the most important one here is the left gastroepiploic, which supplies the greater curvature of the stomach. So it supplies this part here. And anastomosis with the right gastroepiploic artery, which comes from the common hepatic. So it goes together. We also have something called the short gastric, which appear on here. So this is your short gastric ones, and it's just the sort of the tip of the stomach. It's the fundus of the stomach. So short gastric supply the fundus, gastroepiploic, greater curvature, and left gastric just the lesser curvature. We also have some pancreatic branches, which sort of supply the body and the tail of the pancreas, but not the head. The head receives a different supply. Now we also have the common hepatic artery. So that's the only one that goes from the right, and it's quite a complex artery. It's the only artery that goes to the liver. So that's quite important to know. And it sort of travels past the superior aspect of the duodenum. So you can imagine the duodenum right here. So it travels past that, and then it has 2 terminal branches. It has the proper hepatic, which is the one that goes towards the liver. So this here, if you can imagine, is the liver. Right, the liver. So that one that's called the proper hepatic. And we have the gastroduodenal artery. Now all of these have multiple branches coming from them. The proper hepatic goes through the lesser omentum, towards the liver. It gives rise to the right gastric, so the right gastric artery, which anastomosis here with the left gastric. It gives out the right and left hepatic arteries for the liver, and also gives the cystic artery, which goes to the cystic duct, right there. So that's the cystic artery, which goes cystic duct and gallbladder. Yeah. The gastroduodenal artery, it's the second branch, and it descends posteriorly and it goes above the duodenum. And it has the right gastroepiploic, so it sort of goes behind right here. So that's the duodenum there. So it goes behind and it joins here to give to anastomosis with the left gastroepiploic to form the greater curvature. And then we have the superior pancreaticoduodenal artery, which sort of goes through here, and you have the pancreas right there, and it supplies the pancreas. And this supplies the head of the pancreas, right? So that's the head. Very important to consider in cancers. Now this is a simplification here. It's the diagram is sort of simplified, and what we see here is common hepatic, gastroduodenal, right gastroepiploic, which goes to the stomach. This one goes to the head of the pancreas. Left gastric artery goes through the top. Oops, sorry about that. Left gastric artery goes through the top. It supplies the esophagus. Splenic artery goes to the spleen and supplies parts of the pancreas as well. And then the common hepatic, right gastric artery, proper hepatic, left hepatic, right hepatic, and a small branch for the cystic duct. This is a sort of good picture to keep in your mind when you're looking at the different blood supplies. So that's the first part. Done. What we'll be looking at now is some sample questions. If anyone has any questions from anything that I've talked about, do let me know. And if not, we'll just move on to the next part. So this is a sort of simple diagram here. This question almost comes up every year, talking about the histology. And what do we see here? So we see that the first one here is the vein, so that would be the vein, and that's the artery. How do we know this? Quite simply, we have a thicker muscular layer here, so the staining here has stained the muscular quite clearly. This is probably hematoxylin staining. And we have the fibrous layer. So as you can see, the muscles are found within the intima, and the fibrous layer are found within the externa. Now here we see a much thinner and wider lumen, so that would be the vein. But sometimes certain arteries can look like this as well if they're squashed during the sampling. And as you can see, they're quite close together. The blue stuff would always be your fibrous tissue, so that would be your external layer. And if I can convince you that these small little layers here, if you can see them, small little layers there, those are your endothelium. And that in the middle, that's the lumen. So that's a vein and an artery, nice and simple. So right here we're looking at the different layers of the arteries and which blood vessel is this likely from. So we need to identify which is the inside and which is the outside. And as you can see, both ends are white. So which one would it be? Now what we know about the tunica intima is that it's 1 cell thick, right? 1 cell thick. So it can't be C, it has to be A. So A is our intima, and that must mean that's our lumen, right? That's our lumen, that's the inside. That's our intima. B is obviously our media because we have the muscles, and C is the tunica adventitia or tunica externa. Now what type of blood vessel is this? So it's likely to be an artery because of the thick muscular layer. But what type of artery? Now here we have to be a little bit speculative and sort of see that this tissue here is quite thick as well and a little bit disorganized. So we can see these little fibers which are sort of interchanged in between with the muscles. So if this was a muscular vessel, you would not have these white streaks. So these little white streaks would not be visible. This would not be visible. This would not be visible. Therefore, it has to have some sort of elastic tissue. And as we can also see, this is pretty thick, it's pretty big. So it has to be an elastic artery with a very thick tunica adventitia. So moving on, we're going to talk about different pulses. So name 8 locations of pulses and how to feel for them. So There's many sites for pulses. You know, they only ask for 8, but there's up to 11. And they have different functions. So for the temporal pulse, you feel it on the temple. It's with your index finger. It's rarely used, but it can be used to monitor circulation, and you hold this down if you get scalp bleeding. So let's say someone gets a cut here, or they're just bleeding. You want to push that down there because that's what supplies the scalp. So you push down really hard and it stops the bleeding. You can also do temporal artery biopsies here. So you find that pulse and you puncture there for a biopsy. A femoral pulse, so you feel along the thigh. It's halfway between the pubic symphysis, so the center here, and the anterior superior iliac spine, and you go like halfway there. It's the middle index finger. It's very important to find this pulse because if you have an accident emergency patient, they'll be lying down. And it's quite easy to quickly feel this this pulse to see if everything's okay. This pulse is very important in orthopedic surgery because you do not want to hit this artery, otherwise you get a lot of bleeding when you're trying to replace a hip. Popliteal pulse, so you palpate this on the knee. This is quite tricky to feel. So you have to sort of use your middle and index fingers and dig in deep, and you sort of pull back, because what you're trying to do when you feel a pulse, you're pressing the artery against something. So you're essentially pressing it against the cartilage and the bone of the leg. So you have to, really dig in with your fingers. You want to be careful, however, if it's an elderly or frail patient, you do not want to just yank at their knee because that can cause pain and bruising. But it's quite tricky to find this one. Posterior tibial, so this is very commonly found and very easy to find. So you go posteriorly, inferiorly to the medial malleolus, so that's the little bony part of your foot, and you use your middle and index finger and you press the tibial artery against the bone. And everyone should be able to find this. It should be found in every single person. If it is absent, it's a sign of peripheral artery disease, or you just missed it. So if it's a patient who's a smoker and they've diabetes and they've had vascular problems and they have pains in their legs and you can't feel the pulse, well, that suggests that the blood vessels are not perfusing properly. E is carotid pulse. So this is what we commonly think of when we check someone's pulse. You can feel it under the neck. So it's under the jaw, lateral to the larynx and trachea, middle and index fingers, and you hold this down during emergencies to check for signs of life. What you can also do is you can massage it, and once you massage it, it slows down the heart rate. So let's say someone's being very tachycardic and their heart rate's really high. What you can do is you just massage the arteries, and it's called a vasovagal massage. What you can also do if you want to be, if you do it on both sides, is that it drastically decreases the blood pressure. And the reason for this is because the vagus nerve follows through that pulse. So when you're palpating for a pulse, never do it with both sides because you can accidentally massage it and the patient can sort of collapse. It has happened. I've seen it happen before when you use both hands on a patient. So it's always one side. Brachial pulse. So it's palpated on the anterior aspect of the elbow. So you go from the front. And it's easier when you extend your arm out and you feel the pulse that way. Easier with an outstretched hand. And it's the middle index finger. And it's quite important when you're trying to measure blood pressure using a stethoscope. So you want to try to find that pulse and put your stethoscope there to measure the blood pressure. The radial pulse, that's also another common place where you feel someone's pulse. So it's just like here. And you want to go near the base of the thumb, underlying the bone, and you push. Very common. And you also palpate the ulnar pulse, which is right next to it, and it's called an Allen's test. And this is prior to doing an arterial blood gas to check for collateral circulation. Finally, we have dorsalis pedis. So this is quite common to find as well. It's between the first and second toes, and it's on the medial sort of side of the dorsum, and use the middle and index fingers. I would strongly encourage you that you try to find your own pulses. It's a good thing to be able to do, to just quickly find it. And once you're in clinical sort of setting, it will make you seem much more clever and professional than if you're struggling to find it. Especially to patients, because you're trying to feel for the pulse, and the worst thing is you're looking, and you can't find it. Especially if the patient is either too skinny, it's usually easier. But if they have a larger body habitus, you need to be very careful and look for your landmarks, right? So that's why you go for temporal, or you look for the jaw and you try to feel the pulse there. Other pulses include the apical pulse, so that's the heart, so you feel it here under the chest. An abdominal pulse, you can feel that if they have an aorta that's pulsating. So final question, one of the final questions, how do pulses come to be? So all these pulses is that the contraction of the heart from the heart here goes out and it creates a wave, right? It creates a volume that's ejected into the arterial tree, causes a pressure wave, and it reverberates. Now, it's palpable with every single heartbeat because the pump is hitting the arteries. And it's the sort of compression of the blood against the arteries which causes the pressure. Now, if you palpate it against bone or cartilage, something very solid, you can feel the pulse itself, you can feel the pressure. And when we measure blood pressure, what we're actually doing is you're compressing the arm so that you can compare the pulse to the artery. So you're compressing it to the surrounding tissues, and so that you can compare the pressure of the cuff versus the pressure inside the cuff. So that's how pulses come about to be. So another question, what is an aneurysm? So an aneurysm is a localized dilatation of the artery that exceeds 50% of this diameter. And what we can see here is that the blood vessel dilates, and eventually you create this little new sac here. There's different types. You have a full aneurysm, or a true aneurysm is if you have the adventitious media and the intima together. A false aneurysm is if it's only one of the layers. This would be a false aneurysm. And what happens is that the structural change is caused by weakened walls and hemodynamic forces. So the wall is weakened, the blood gushes and it expands, and therefore you have a weakened wall. And it's usually the tunica media that's also weakened, that stretches out. So essentially, localized dilatation, weakened walls and hemodynamic forces, and in a true aneurysm, the externa, media and intima are all involved. So finally, outline Laplace's law. So the law of Laplace is a physics equation, and it talks about tension. So tension within a system is how much pressure you're sort of putting on the edges, and it's the wall tension. And your tension varies directly with the radius. Now, if the radius expands, right, the larger the tension around the wall. Now, if the wall is weak, well, then the tension takes over and the wall dilates, and it will expand to the point where it eventually bursts. So what happens, a quick overview, tension varies with the radius when the pressure is constant. You have a larger radius, then you need a larger wall tension needed. But if you have a weak wall for whatever reason, old age, damage to it, it causes an expansion and you get an aneurysm. Aneurysm ruptures once the wall becomes thin and weak enough and not strong enough to maintain the pressure. Okay, this is the final question, sorry. So describe the concept of an anastomosis. So an anastomosis is essentially a joining, so that it's a natural joining or surgical joining of tubular structures. So that could be arteries, that can be veins, or even intestines. Now there's two different types. So you can have a functional anastomosis or an anatomical one. So an anatomical anastomosis is when the circle of, for example, circle of Willis in the brain. And it's when the arteries come together and they communicate directly. And if one artery is blocked, then the blood will still flow through another part. So if you're blocked here, it will still be able to flow through here. This is called an anatomical one, where they all join together. You also have something called a functional anastomosis, which is found in the large intestine in the mesentery. So rather than forming a direct circuit with the blood vessels, they form a circuit through the tissues. So they behave as an anastomosis. So for example, one of them gets cut off, but you still get supply through another because of the tissue, but it's not a true anastomosis. It's not a proper anatomical one. Now we can also get surgical anastomoses. So we can get different grafts. So let's say one of your arteries is not working so well, like in the leg. You can have an end of artery anastomosis. So if it's in the forearm, it's usually given for patients with, if you give them hemodialysis for easy access. And in the legs, you can use the great saphenous vein to redirect the femoral artery. So you take it from the leg and you put it in the femur, in the femoral artery area. You can have end to end, so that's just one joining like this. You can have side to side where they're joined like that. Or you can also have an end to end where it's actually joining one another. Alternatively, we can also have for the intestines. So this is a surgical anastomosis of intestines, where you suture two intestines together, either after you've cut them out. So let's say there's a tumor, there was a tumor here, they cut it out and then they sutured it together. So briefly, to sort of reiterate, anastomosis is a natural or surgical joining of two tubular structures, artery, vein, or intestines. Anatomical arteries, they communicate directly via circuit. Functional anastomoses, they communicate through the tissues. Now, so that is all. I hope that was useful for all of you. It was a sort of brief overview for both year 1 and year 2. There have been quite a lot of requests to talk about the vascular tree, and it's sort of like a rundown of all the different blood vessels and how they work, and also how everything interacts with one another in terms of the branches of the aorta. Now, I hope this has been useful. If it has, that's great. If there's any questions, just post them here, or you can email them directly to, I'll put it here in the chat, geoclinicalanatomy@gmail.com, and you can just send it there and we'll answer them. So yeah, if there's any questions, do let them through. If not, thank you for watching. I hope this is useful. It will all be made, you can watch it whenever you want within 24 hours. That's just how YouTube works. And yeah, thank you for your time, and have a nice weekend, guys. So if there's any questions, just do ask, just pop them down, and if not, then we'll just end the stream there. Okay, looks like there's no questions, so have a nice weekend, guys, and I hope this has been helpful for your revision.